Thank you, Moses. Thank you for everyone being here. Thank you to Josh. Thank you for all the presenters. But really, thank you. Whenever I see like a room full of people, it's always just amazing to see how many people want to better themselves, right? So I feel like I get better from a room of other people who want to get better too, because we're all sharing ideas. We're all sharing things that we do in our practice that works for us, right? So one of my favorite parts is, of course, it's to speak, is to talk about what I do, but it's also to see what you guys do, because at the end of the day, we all want to get results, and we're all seeing results in our practice, but we all want to get better. I think for a long time when I was just getting out and just getting going, there were days where I was like, things weren't working, right? And I was like, wow, like I did all this schooling and none of it's helping. And then I felt like I really suck, right? And then I have to go and I have to take a course and try to get better. And then I have to go back to my office and then again, try it out and see if it's gonna work. And then there are days where I was like, wow, I'm getting this stuff. And then there are other days where I'm like, I don't get it. Why isn't it working for me, right? So it was great when I finally met, Josh and Anthony Lombardi, of course, and, things started to get better and my outcomes got better as well. And then there were times when I still went back to my office and I was like, things are better, but I'm still getting a little bit stuck with some patients, right? And then it made me be like, wow, like I need to go and learn more. I need to go and take symposiums and take more courses. And I was like, well, if I was just Anthony Lombardi, I'd probably fix everything, right? Or if I was just, had Moses' vastus medialis, I'd probably fix everything too, right? Or, if I had, if I had Jamie Chavez's brain and the way he can assess things and like all the numbers and figures that he has in his head, if I had that skill, then I can go to my office and I could fix everything, right? If I had Darren's hair and beard, I'd probably fix everything, And even if I had Jamie Hampton's like compassion, right? Like we've heard it up here. She's helping people that I've never had to deal with those kinds of things, but the way she deals with it and the way she can, comfort these patients to telling them or telling her like what's going on in their lives, that's amazing, right? So again, like me being here and you guys being here, that's like the most incredible thing because we're all learning. We're all hopefully going to come back to our practice and do amazing things. So thank you guys. So today we're going to talk about rehab. Okay. So Moses did a great job of giving a little bit of a bio. So I'm a doctor of chiropractic. I have a master's in sports science or sports performance and physical rehab, and that's why I do a lot of rehab in my office. Again, whenever I was met with some kind of roadblock, I felt like I needed to go back to school, right? So whenever I met a roadblock where I was like, wow, this person is coming in and they have performance goals, I need to figure out how I can get them there. And that's what led me to go and get my master's in sports performance and physical rehab. And then I did an internship at Advanced Training and Rehab, which was a physical therapy clinic, right? And it was just one of your regular physical therapy clinics, but from a perspective of being in one of these clinics, knowing what I knew, whether it was chiropractic or acupuncture, because I was trained in TCM. That's what was my very first thing, was 100% TCM practice. And then I went and I trained for a long time with Dr. Tan. I followed him around the country. I took tons of Dr. Tan. I took tons of master tongue points. That's all I did for years. I never, ever did electroacupuncture for a long time. So anyways, I worked in one of these PT clinics, and it was very interesting to see what the standardized PT care is. And then it really made sense when I saw a lot of patients coming into my office and why they failed a lot of times physical therapy, right? So it was a really good learning experience. And just like all of us, if we've been inside of different clinics and offices, it's always a good experience to see what's worked for people and what hasn't worked for people. So, and I'll kind of tell you some stories from a PT clinic. It's interesting. Of course, so then I was certified in acupuncture. Like I said, I did tons of training, went all over the country to try to learn just the latest and greatest techniques when it came to acupuncture. I'm the owner of Lova Health, and that's my private practice, and that's where I treat patients every day. I'm the current team physician for a pro women's basketball team, like Moses said, which is great. We won 2 national championships. It's amazing to see, these girls who are, they're young, and then they go and play overseas. So most of these girls, they play in St. Louis, and then they go to Israel, Romania, England, Germany, and they play professionally over there. And then in the summer months, they come to St. Louis, and they play locally at a university in St. Louis. And we've been very fortunate to be a part of their sports medicine team. I'm also the current team physician for MADCO, which is a modern American dance company. So I treat a lot of professional dancers, which is, again, it's completely different from a basketball player. But when you see dancers, you see tons of issues. And I think, again, taking away from things that Jamie talked today, when you're dealing with just women, sometimes you have to open up different doors. And now I know how to talk to them, maybe a little bit different. So again, I'm learning so much, but tons of musculoskeletal issues when it comes to dancers as well. And then just recently this year, I became the current team physician for the St. Louis City, which is the MLS, the Major League Soccer. So I get to be with the whole sports medicine team when it comes to Major League Soccer. So my office looks like a humongous stadium. I get to walk into a training center with the top orthopedists in St. Louis, the top concussion specialists, neurologists, physical therapists, athletic trainers, and I get to be on their staff. And the coolest part about that is that I'm respected for everything that I do, whether it's acupuncture or chiropractic or rehab. It's just cool to be in a circle of people who everyone gets to put their input in it, right? It's of course, you still need to stay in your lane and you still got to treat what you treat, but it's really cool when you have people who we can all put our minds together to get the best from an athlete. And these athletes, they're like 15, 16, 17, up to maybe 25 years old, and they're the best in the world. I mean, the best in the country that, that MLS team kind of can get. So it's really fun to treat, of course, professional athletes. I get to do that very often. I feel blessed. That's actually my dream job, was to always work with pro athletes. So I'm doing it, right? So, you try hard to kind of get to those places, but once you finally do, you want to be the best. And that's when you go and take a ton of courses and you have amazing mentors, and then you can do really cool things, and then you can be in the position to treat who you want to treat. So really fun. So a lot of times my schedule will be all over the place. It'll be a professional dancer, it'll be a professional basketball player, it'll be a professional soccer player. But then when I'm at my private office, it's everybody else. So I get to see anything and everything. So practice is fun. Another thing that I do is I'm the owner of Furman Institute of Health, and what this is, it's an on-site health and wellness services. What I did for a long time, and I'm also giving the marketing talk tomorrow, so this will kind of blend into that, but when I was first starting my practice, I needed to get patients in the door. So I would do a ton of health fairs and marketing. And then after I did a ton of marketing and events and things like that, I then told the company, said, hey, I'm already here for a health fair. Is there more that I could do? Can I give a lecture? Can I come back and do a different, ergonomic testing and stuff like that? And then eventually what happened was I asked them if I can become the official chiropractor for the company, or if I can bring massage therapists on site to the company. And then now currently, or actually before COVID, I was the official chiropractor for Build-A-Bear World Headquarters, for Pepsi Corporation, for Cintas Corporation, for another company called Foam Supplies, 2 locations. And now I can't do them all myself, so I was able to hire on people who work underneath me, and we have people go on site to all these companies, and they do soft tissue work, and they do massage therapy. So there's endless possibilities when it comes to getting people involved or getting health and wellness into companies or getting health and wellness into pro sports teams. So, but we'll talk a lot about that tomorrow, okay? And then, of course, teacher assistant to Dr. Anthony Lombardi. Can't say enough. Mentor to me, I'm sure to a lot of people here. So I definitely recommend taking courses with him. It definitely has changed my practice for the better. Great. So enough about me. We're going to do... So who here shows or tells their patients exercises or stretches? Does anyone tell people yeah, cool. So a lot of people are already doing exercises and stretches in the office. The thing that, because rehab can be many different ways. You can do rehab when it comes to athletes, or you can just do simple stuff. Sometimes we can just show them basic stretches. I think when it comes to exercises though, is sometimes we got to be careful, because a lot of times people are coming in and they already are doing exercise. Maybe they're already doing yoga and they're doing bar and they're doing all these different classes that people are seeing nowadays too, and they think they can just continue to do those exercises. Well, maybe, right, but maybe not. And we are maybe the first person that's going to tell them, hey, listen, these are the exercises that you should be doing, or these are the exercises you shouldn't be doing, because you're trying to get them better. So you don't want them getting in their own way when it comes to them getting better, right? Because they think by going to yoga sometimes that they're fixing all their pain, especially when it comes to low back pain. Oh, I heard yoga is good for lower back pain. I'm just going to continue to go to yoga even though my back hurts. you might be making it worse, right? So if they're coming into your office complaining of lower back pain and they're still doing all this yoga, you're sometimes going to have to break them the bad news, you know? But I never tell anyone to stop because nobody wants to stop doing what they're doing, especially if they're an active person. That's what they love to do. So you never want to take that away from them. You just want to find ways where maybe you have to modify some things. And we'll go through a lot of that today too. But of course, first we're gonna go through the anatomy. It's always good to know things about when it comes to low back rehab. We got to understand the spine first. We got to understand how the spine moves so that we can actually rehab the spine too. Then we're going to develop a progression of exercises to train the spine. A lot of times people are coming in like, well, I looked these exercises up on YouTube, right? They already have the top 5 stretches and the top 10 exercises for lower back pain. I'm like, well, if you already have it, why'd you come into my office? You already got the fix, right? So, and it's because most people don't know where to start when they have pain. They just start with the internet, and unfortunately the internet is just very general. It's very broad, and it's not specific to them. So we want to tell them that right away whenever they come in. You say, hey, listen, I know you have all these stretches and exercises. You probably have gone to physical therapy maybe before. They gave you a whole entire sheet of exercises. Generally, when they tell me they've done a bunch of exercises, I'm like, stop doing all of them because they might be too general or they may be too much, too soon, right? That kind of thing. So we kind of want to understand how we can either progress an exercise in terms of advance an exercise, or we need to sometimes dumb it down and regress an activity so that things can kind of catch up and they can get stronger. So we'll learn how to do that today. Understand when and how to advance, of course, an exercise, when they're ready for it, and what to look for when they are ready. Because how do we know when someone's ready to do a plank? How do we know when someone's ready to do, a downward facing dog? How do you know you're ready? You say, well, just try it. Let's just see if it feels better. Well, there should be some kind of systematic way. Again, at the end of the day, I think one thing that I've learned whenever I took all these seminars for so many years is that I was just looking for a system. I was looking for how to analyze something. I was looking for like, when do I do this? And then when do I know I can do that? Because if you don't have that, then you're just shooting from the hip. You're just kind of just throwing everything at it and hoping that they're going to come in and be like, oh my God, whatever you did last time, do that again. And then you're going to be like, I don't even remember what I did last time. Because there's no system to it, so you're not going to really be able to like track your progress, and then how are you going to do it to the next person, right? So, because everyone responds differently. So we have to know what we're doing so that we can get the results that we want at the end of the day. And then understand the relationship between the spine and the rest of the body, and how it relates to the pain to performance continuum, which we'll go through that as well, okay? So, first question, what does the spine do? Now, this can be answered in many different ways. Everyone's probably going to have a different answer for what the spine does. This class or this lecture, it's not the most definitive thing, like it's only like this. I think everyone in every course that you're going to take, everyone's going to have a different answer for what the spine does. But in basic premise that I think the spine does is just a transfer of energy between our legs to our arms whenever we're moving. The spine has to be stable, the spine has to be mobile so that we can perform all of our functional activities, okay? So if we look at some of these pictures, so the person or the picture on the left, that's Usain Bolt. He's the world's fastest man, right? We can probably assume that he's got a pretty stable spine, and he probably has an amazing ability to transfer energy down to his legs, up through his arms to generate that much force. So he's going to have an incredible ability to adapt, or an amazing ability to perform because of his stability in his spine. Same thing if we look at this weightlifter on the right. This person is lifting a ton of weight over their head. You better believe that their lumbar spine is going to be pretty darn stable to be able to do that. Because if you didn't train for it, your spine would probably collapse if that's not something that you can do, right? So it's pretty incredible what the human spine can do if we build up the spine to do that, right? So pretty incredible things that people can do. Next thing is, now this is probably what we see in our office all day long, right? Grandparents who just need to lift up their grandkid. Right? This is what I see every day. Someone comes in like, I have lower back pain when I lift up my kid. So we have to figure out how can we get that person to be able to do that activity. Same thing. I reach down to get a plate out of my dishwasher, and then boom, I have lower back pain. And sometimes the person's like, I've never had lower back pain in my whole entire life. And then I did this one thing, and this is what took my back out. And then they love to tell you, oh, back in the day, I played football. I was the captain of the team. Like everybody's got like, a story of how great they were. And then it's always, I sneezed and I blew my back out, right? And they're really pissed. And then we have to explain to them like, okay, like, but did you stop doing the things that you were doing when you were a football player? Did you stop stretching? You stop moving? You stop, caring about your body a little bit? So, again, it comes down to like patient education, but everyone is really surprised when they first get pain because a lot of times when they come in, they don't really know what happened because a lot of times it's not from a trauma. Now, when I deal with professional athletes, it's usually sometimes from a trauma, right? Because they get hit, they get knocked. But in cases that I see every single day at just private office, these people don't really know what happened. So we have to explain to them how we can make their spine more mobile, more stable, so they can even do the basic activities too, okay? There we go, okay. So one thing about the spine that's really interesting that I think this does a really good chart or an example of it. This is just the golf swing. I remember that Anthony kind of went over this with Moses when we were talking about the sports acupuncture. But there's a kinematic sequence, and what that means is that the body just doesn't move like one big unit. There's actually things that occur in like this kinetic kind of linking, or kind of there's a specific sequence that happens for the next event to kind of go on. So if we're going to look at a golf swing, when this person kind of brings this club back, what this lines kind of show is that first the pelvis is having to kind of move through that sequence first to kind of build up this springiness, right? Once that occurs, then what we have is now the thorax or like the trunk, that kind of starts to kind of get a little bit, starts to get the rotation happening after that. After that, we get the arm swing that happens going downwards, and then the very last thing is going to be the club. And what that's pretty much showing is that the human body doesn't move as just one unit. There has to be a sequence of events to happen for the body to move in this kind of stability kind of phase. So we're about to see a video of actually Tiger Woods, who is considered one of the best golfers in history. But the reason he's the best is because he can produce power because he can dissociate between his hips, between his thorax, between his shoulders and arms, and then get amazing speed coming from his golf club. Which I think whenever we think about how the body moves, we need to start to look at things, yes, individually, but then how they all work together at the end of the day too. So let's see. Okay, so what we're going to be looking for is we're going to be looking for how he's able to use his hips independently of his trunk, independently of his shoulders, and then when he brings the club down. So let's see. Good, it's going to slow down here in a second. So see, first the hips move, then the trunk moves, so we're going to go into slow motion now. So as he brings this back, watch his belt. There it moves, then the trunk moves. It's going to go even slower here in a second. So first here, then he brings that back, then his arms come through. So he's got an amazing ability to be able to bring this back and actually disassociate between his hips and the rest of his lumbar spine. So his lumbar spine has to be amazingly strong because it's staying still. It's winding this up. Watch his belt. First, this is going to move forward, and then the rest of the body goes through. And that's how he can generate so much power and so much speed, because he's got the ability to have super mobile hips, yet a very, very stable lumbar spine. Oh yeah, and then you can switch it off. So we're all going to be amazing golfers by the end of this, right? Hopefully. But I see a lot of golfers, and a lot of golfers come in with lower back pain. So one thing that we want to point out with them is, well, are they using their hips? Do they have a stable lumbar spine? So that we can really help them understand what's going on with their spine in the first place. Because again, when people come in, they have no idea why they're having pain. So they're kind of leaving it up to you to explain to them. And if they're an athlete, or if they even just do it kind of recreationally, you kind of want to explain what's going on. And again, the first place that I like to start with is with the anatomy. So, this is actually one thing that has really, really helped me in practice. I feel like a lot of people don't know about this, but it's called the joint-by-joint approach. And this was created by Mike Boyle and Gray Cook. So Mike Boyle, he's a strength and conditioning coach, and Gray Cook, he's a physical therapist. And what they found was whenever they were treating, or mostly Gray Cook, when he was treating, he found that there are certain areas of the body that should be more stable, and there's certain areas of the body that should be more mobile. We all know that, starting from the bottom of our feet, our ankles should have good mobility. Our knees should be very stable. Whenever we walk, our ankle needs to be able to plantar flex and dorsiflex. If it doesn't, then it's probably going to start to kind of leak into the knee. If we just look at the anatomy alone, the ankle joint, we can move it a lot, right? It's very, very mobile. The knee itself, it's got tons of ligaments around it. So the body's already designed for it to be very stable, and that's why it's already created all these ligaments around it. When we go up to the hip, we want to be super mobile in our hips, right? We have a big kind of joint in there that likes to have a lot of freedom to move, so we want our hips to be super, super mobile. When it comes to the lumbar spine, we want it to be very, very stable. Again, look how many ligaments and how many big muscles we have around our lumbar spine. We want to make sure that it's super stable. When it comes to our mid-back, we want to be very mobile. A lot of times we see a lot of people are kind of hunched down like this, right? They're super tight throughout their mid-back. So if they lost that ability to be mobile throughout their mid-spine. And same thing with the cervical spine. We want to be very, very stable in our cervical spine. So a lot of times, whenever we see, let's just take for an example, knee pain, right? How many times do they actually say we should be looking up to the hips, right? Because if our hips are very not stable or not very mobile, then that could be cause of the knee instability. Same thing when it comes to neck pain, for example. And I know this is a low back rehab, but with neck pain, if our mid-back is very, very stiff, a lot of times it could be causing instability in our neck as well. So we kind of want to be looking above and below the joints because that could be actually the root cause of the problem. A lot of times what happens is, especially in lower back pain, is if we're not mobile in our hips, then the mobility is going to have to come from somewhere. And it usually is going to come from the lower back, because the body's going to have to compensate in some kind of area. So if they have super stiff hips, so instead of using their hips, they're going to start to rob some of that mobility from the lumbar spine, and then that's when people get lower back pain. So for example, in the golf swing, if the person doesn't have the ability to actually extend through their hips because they don't have hip mobility, the first place they're going to use is going to use their lower back. And they're going to arch their lower back to get more motion because they're not going to get it from their hips, and then they're just going to crank on that back all day long. And then they're going to come to your office and be like, I got terrible lower back pain. The first place that I'm going to look, it's going to be at the hips, because I guarantee you that those hips are stiff, and most likely because they sit all day long, they have no mobility in their hips, and then they try to go out there and play golf every single weekend, and then hello, lower back pain. So same thing when it comes to the knee, which I see the knee a ton in my office. If they come in and they're complaining of knee pain, I'm still assessing the knee. We still have to do a good assessment. But you better believe the next place I'm going to is usually the hip. I'm going to see what the hip abductors are doing, if they're strong, if they're weak, or if there just has no mobility. And I'm also going to look at the ankle to see if there's no motion coming from that ankle. Just an interesting thing, just the other week, and sometimes I just like to, when you're in practice, sometimes you like to try things because it's just interesting. You learn new things, you're like, okay, I'm going to do this point today, or I'm going to do this soft tissue technique today. So I had a woman come in, and she takes boxing classes, right? And she's in her 50s, has 4 kids, and she was saying, oh my God, my knee is just an 8, 9 out of 10. All I'm taking is Motrin, right? So I said, okay. So she comes in, and she says, she's got pain around her knee joint in the front. And I say, okay, well, I know that she didn't land on her knee. She said she didn't twist her knee. She walked in a little bit gingerly, but it didn't look like her knee was too bad. I didn't see any inflammation, any swelling around the knee. But I wanted to look at the hips, and I wanted to look at the ankle. So I had her lay on her back, and I had her just bring both toes up towards her. And on the side that her knee was hurting her, she had barely any dorsiflexion. It was super limited on that same side that she had that knee pain. I said, okay, that's interesting. There goes the ankle. And then I said, okay, I'm like, have you had in the past any hip issues, any, low back pain? Oh yeah, I had a L5, L4, disc herniation that they did a discectomy on. I used to have a ton of hip stuff. I'm always super stiff in my hips. I'm okay, another thing. So I'm like crossing all these things off in my head. I'm finding the ankle, I'm finding the hip, and there's nothing that I can really find on the knee. And it's one visit, and she's like 8, 9, 10 out of pain, right? So I'm like, what am I gonna do? Should I stick some needles in it? Should I go for the glutes? Our head, you're doing an assessment. So I'm like, no, you know what I'm gonna do today? All I wanna test out is can I get better mobility in her ankle and better mobility in her hips? Let me just see if I can do that. So that's all I did. I did soft tissue on the ankle, I did soft tissue on the hip, and then I had to go leave the office. She came in the next day. She's like, holy crap, I told everybody about you. My knee there's no pain in my knee. And I think what happened is because since now she was getting better motion in her ankle, she can actually move forward without putting strain on her knee, because now she can actually bend that ankle going forward. And then since she was getting better mobility in her hips, she can actually use her hips to lean down instead of having to use so much of her knee to move down, right? Because if you think about it, whenever we bend, whenever we move, if we do it in the right sequence of events, we're actually going to be using our hips to be able to bend back. What most people do is they use their lower back to bend, and they use a ton of their quads and their knees, and that's why they put so much force going forward. So that's why people generally get a lot of issues, is because they're just using their body in like the most inefficient way. But if we actually look at the joint-by-joint approach and actually use these to our advantage and help our patients get these mobilities and stabilities back to those joints, then they're going to start feeling much, much better. Another really interesting thing about the joint-by-joint approach is, when we look at the knee, we want stability, right? When we look at the lower back, we want stability. When we look at the cervical spine, we want stability. If you look at those three areas, where are the most braces sold? In terms of if you go to Walgreens or the stores, what kind of braces can you get? You can get a knee brace, you can get a low back brace, and after a car accident, they give you a cervical collar, right? So even the consumer goods that we can get, they're all showing us what are the most common complaints that people are having and where they're lacking the stability. And that's why we have to buy braces all the time to stabilize these joints. Well, why don't we help our patients stabilize those joints for them without having to use a brace? Because we all know that brace that they're putting on isn't doing a thing. It's nothing, right? It's just a Band-Aid, and it just makes them feel a little bit better for a little bit. Now, of course, if something's super unstable, then you have to put a brace on it. But if I'm walking around, I'm at the airport, and I see all these people with knee braces on, it's just a Band-Aid. They probably haven't really fixed the source of their problem, whether it's coming from their hip, whether it's coming from their ankle, right? So I look at this quite a bit now whenever I assess a patient. It's not just orthopedic tests or just muscle tests. I'm also going to be looking at, let's look at the mobility and stability of the joints too, okay? So let's look at the anatomy. So this is the lumbar spine. Of course, we know that there's 5 lumbar vertebrae, 12 thoracic vertebrae, 7 cervical. Of course, we have our iliums, our sacrum, coccyx, and this is kind of like an anchor, right? So we just know that we have to be very, very stable in this part of our spine, the lumbar spine. Yeah, that's good. So if we add the next one, we can see if we add the muscles, we have the multifida muscles, multifidus. We also have, these intrinsic little muscles in between the spine as well. And these are our stabilizing muscles. These are the muscles that we want to make sure are the strongest muscles, right? Because they're going to help keep the lumbar spine erect. We also want to note that the QLs, that's a very important muscle as well when it comes to lumbar spine stability. That is it for this picture. Yep. If we move on to the next slide, if we look at the front of the spine, we can see that we have our psoas muscle. So the psoas attaches to the lumbar vertebrae, goes down and attaches to the greater trochanter. At the top, I wish I had a little bit of a better picture here, but we have our diaphragm. On the sides, we have our transverse abdominis. So if someone is really tight in the front of their hips, it can definitely start to tug on our lumbar spine too. So that's why it's important to not just think about just the the backside, just the posterior muscles, just the multifidus muscle, or just the QL muscles, because at the end of the day, we can't ever blame just one muscle. We kind of have to look at the diaphragm is super important. I think we've heard the diaphragm many times this weekend. This isn't a breathing class, but I recommend there's a lot of amazing things when it comes to how to properly breathe. I keep on hearing this, and patients are coming in and telling me about, the breathing things that they're doing, and there's so much to it, right? But the way I look at it is like, well, what muscle is being involved in that? And we know that it's part of it is because of the diaphragm, and it's just one of our intrinsic core muscles that a lot of times people don't really think of. They just think of the abs, right? They don't think that the diaphragm is that important. So I definitely recommend looking more into those breathing classes, or just assessing a little bit more of those deeper kind of core muscles. And then if we kind of put now more of the superficial layer muscles on, one place we can always rely on being tight in the lower back is like this thoracolumbar fascia that we have back and through here. But look how much it spans. I mean, it goes from all the way down into the hips, into the sacrum, all the way up into like the thoracic spine as well. So soft tissue-wise, this is just a gold mine of where people are constantly they're tight, right? That's the one thing that we're always hearing when it comes to low back pain. It's like, I'm tight. I have a lot of lower back pain. It's always tight in that area. Well, why is that, right? Why is the fascia having to do so much more? And it's because most likely all the muscles that should be super stable aren't doing their job, and it's relying on other tissue to start to do that. So, but this is a gold mine for treating lower back pain as well. When we look at the front, of course, then more the superficial muscles, we have our rectus abdominis muscles, we have our oblique muscles, TA, transverse abdominis muscle. So again, this has a lot to do with how we stabilize our lumbar spine, but we want to know those muscles because people are coming in and they don't know any of this information. They don't know what's going on and why they're having lower back pain. But it's nice to sometimes show them these are the muscles that are responsible for your core stability, or this is what your core actually is. And it's not just abs, right? You kind of want to explain to them that there's more going on internally that we also want to start to work on as well. Now, one thing that's now my favorite in terms of, not favorite, but was really kind of piqued my curiosity is fascia. And, I think we've even heard it talked about a lot this weekend as well. And it's been a lot of the new courses that I'm taking is all on fascia because fascia is quite incredible. And there's so much that we should be treating when it comes to fascia because I think that's like another key component to getting a person back performing well, or even when we talk to performing, is just moving well. If we can really unlock some of this fascia, and we can do it using acupuncture, we can use soft tissue, and we can use rehab to really unlock this, it's an incredible resource. And one person that's just very well known for it is anatomy trained Thomas Myers. And I think he was a massage therapist who then he went and did a lot of cadaver studies, and he found that there's these slings or lines of tension in the body, almost like these pouches that encase all of these muscles. And it's quite incredible how we have all of these different fascial slings and how it ties into just basic movement of the human body. So I'll kind of go through some fascial lines that we see. So the fascia runs all the way from our feet all the way up to our head, and one we can look at is, of course, the deep neck flexors all the way up and through here, runs down to the rectus abdominis, rectus femoris, quadriceps, anterior tibialis, digital extensor. So when someone just reaches up and kind of goes back like that, that's stretching the whole entire anterior fascial line, right? So it's really helpful when we're dealing with lower back pain, or even if we're just dealing with motion deficits, because we're not just looking at the lower back now, right? We have to actually look at the whole entire fascial line, because if we miss it, it's maybe because we're not looking where we should be. We're just kind of looking at just where the problem is, or just where they tell us where the problem is, right? The posterior fascial line, so it starts with the frontalis, which is actually in the front of our head, but it wraps back around, goes down to the erector spinae muscles, to the sacrotuberous ligament, down to the hamstrings, down to the gastroc soleus, and even the plantar fascia. So this is a really good example. Most people who've treated plantar fasciitis, right, when it comes into the office, how many times are we looking at the soleus and the gastroc? How many times are we looking up into the hamstrings, all the way up into the glutes, even into the lumbar spine? All the time. I mean, sometimes, yes, it can be a local issue, but how many times are we treating calves and soleus when it comes to the plantar fascia? So we know how important this fascial system is. We have to start looking up, above, and below to really get down to the source of where the issue is. So that's why I love this fascial stuff, because it makes sense, right? Functional diagonal fascial line. This is one very, very long fascial line, but this came up whenever Anthony was assessing Moses, and it was for the swing when we found that there was it was the right shoulder, or maybe the left shoulder, but it could have also, he was having a right hip weakness. So that fascial sling that covers all the way from one part of the spine and crosses over to the opposite hip, opposite foot, there's that whole fascial sling that has to work together. So it's something, again, if someone's having a right issue and you keep on treating that shoulder and it's not getting better, and they're doing all this active kind of stuff, I'd say start looking at the opposite hip. Because if the opposite hip is still having a dysfunction, well, that could be causing that dysfunction up above, and it can definitely be happening up into that shoulder. So you'll be treating that thing all day, every single day, and then they're not going to get results. So it's important to start looking at these fascial lines. Deep core fascial line. This is kind of like our deep, this is all those intrinsic core muscles. So this is actually what makes up the core. At the end of the day, the core is going to be our diaphragm, our transverse abdominis, and then our pelvic floor, which, thank you so much to Jamie, but that was amazing to see how much our pelvic floor is contributing to possibly the lower back pain, and how much we're not looking at it sometimes. Again, when every person that comes in the office, we want to fix, we want to heal. And if we don't fix them, we feel like, again, we suck, right? But maybe it's because we're just not looking at other things. We're saying, well, I don't really treat pelvic floor, or I don't want to go down there, right? And then we're like, I don't know what's wrong with your back pain. I'd probably go back to your PCP. Well, if they go back to their PCP, they're probably just going to get pills. They're probably going to get a cortisone injection. They're probably going to get an MRI, and they're probably not going to get better. And it may be because we actually didn't really assess the full length of everything that's going on, because we don't want to go there. Now, we're not going to be experts at everything, right? We're not going to be expert at pelvic floor. We're not going to be expert at breathing classes. But if we know about it and we know that this thing exists, then we know that if we aren't getting results doing the things that we regularly do, well, maybe we should start to find people in our area that do that kind of stuff, because then that person's going to get results at the end of the day, and they're going to be really thankful that you sent them there. So that's why I like looking more at this kind of stuff as well, because if we're not fixing it with just the regular stuff that we're doing, I'll start looking elsewhere. This is a research study. The only reason I do a lot of research and studies on my slides is because Jamie Chavez is here, and I got to make sure I do that. No, I'm just kidding. But research is super, super important. And people like it in terms of not people like it. It's like we want to, at the end of the day, know that we're doing the most effective stuff, right? We want to know that this stuff has been proven, because a lot of times whenever we do stuff, people are like, oh yeah, like where's the research on acupuncture, and where's the research on chiropractic, and where's the research on this and this and this? And I'm like, there is research, and here's the proof, right? So this is just one study that the coordination of muscle activity to assure stability of the lumbar spine. So we know that the muscles have to work together to make sure that there is stability in the lumbar spine, and we know that the core muscles, they all have a firing sequence. The hips have to work together with the lumbar spine too, to make sure that at the end of the day the lumbar spine stays accurate. So Stuart McGill, he's like one of the leading researchers on lower back pain. So if you look up Stuart McGill, he's got incredible resources when it comes to lower back pain. I've even given his book to patients because it does a really good, easy explanation of what they can do to help with their lower back pain. And it's put into like layman terms. It's not just a bunch of research articles. That's why I like Stuart McGill's stuff. So this is the kind of the pain to performance continuum that I use in my office. When someone first comes into my office, they're having pain, whether it's from a mechanical issue, whether it's from, like they have an injury. Of course, then we're also assessing if it's chronic systemic or is it just a mechanical kind of issue. But my first thing is when they first come in with pain, I'm going to be looking at some kind of motion, right? I'm going to be assessing them for whether they have deficits in mobility or deficits in stability, or how to get them back to having more mobility or back to having better stability. Then my next goal is from mobility to stability is then get them stronger, right? Because you can't just be super mobile and have some strength or some stability back, but you got to then help them get back to some kind of strength. Because how did this happen in the first place is what I always ask myself when someone comes in. When someone comes in with pain, they're probably doing something repetitively that has caused this in the first place, and maybe we got to get them stronger so that this doesn't reoccur, right? So I'm still giving them some kind of strength component so that they can return to their activity better than they were before, so they don't have to keep on coming back to my office for the exact same issue. I love to fix people, be done with it, and never hear that problem again. Because if it keeps on coming back, did I finish my job? Or are they keep on messing themselves up? Or did I not fully rehab them correctly, right? So there's always some kind of strength component to the work that I do in my office. Next is, now when it comes to speed and performance, that's if they want to take it to the next level. And this even happens too, like if we're chasing after our kid and we have to quickly grab them before they fall off of something, well, we have to have the ability to do that quickly, right? So we have to have some component of speed to it, because we can do just a bunch of passive stretches and stretch our hamstring and this feels nice, but how can you go from this to then chasing your kid? Right? It doesn't always equate to that. So you have to still plug in some component of strength, speed, and then get them to their performance. So because we're talking about real life, right? And when we're talking about real life, things happen, right? We have to reach up above, or when we're painting, we're not painting super slow like this, right? We're just going through our motions, right? But if we don't have that ability to do something like that, and we overuse that area again, we're probably going to go through that pain cycle all over again, because we didn't actually finish the whole rehab kind of cycle. So if someone jumps from pain to perform, like let's say a golfer, he comes in, they have lower back pain. I do a treatment, and they get off the table, and they're like, bam, I'm 100%. This is awesome. And they go golfing that weekend. What's going to happen? They're kind of blow their back out, most likely, because they skipped all of these steps. They weren't ready to go to perform. They were just at pain just the day before. And then they went straight to going golfing with their buddies, and guess what? They're right back into my office on Monday. And they probably think that what I did didn't work, right? They thought I was a miracle worker when they first came in because I took them out of pain really quickly. But if we don't explain to them that we have to assess your mobility, assess where you're not stable, get you stronger, and then be able to do that at a speed that you can handle so that you can swing that golf club with strength and stability, then you can go back to performing golf. But if we miss any of these steps in the middle, we're always going to be living in this cycle. The patient's always going to be coming back in with the same pain because we actually never really addressed the stuff in the middle. So, with the things that we do in our office every single day, it's great. We've seen some amazing things. But I think by plugging in some of the stuff that we can do here, you're going to see them have long-term success, okay? So this is a really important slide as well. So when someone comes in my office, I first always still have to ask them, like, the basics. How are you sleeping? How much nutrition are you getting? In terms of good nutrition, are you getting plenty of water? So, and what is your attitude when it comes to pain in the first place? Because if someone is, fearful of moving, or if someone is scared to go back to an activity, that is kind of stuck in their brain psyche. And they keep on reliving that moment, and they're scared that if they bend down to pick up their grandkid, they're going to have lower back pain. So we kind of want to get some of that out from them in the beginning so that we know that, okay, they have a little bit of a fearful kind of hesitation. So what are their mindset and attitude towards getting back to health? If they come in, they're like, man, this sucks. I don't even really want to be here. I don't think any of this stuff works. I know they're going to have a hard time in my office, right? Because they already have a pretty crummy attitude when it comes to this kind of stuff. So how am I going to get them to perform if they're already doing terrible down here? Right? So we've all had those patients before, so we just want to be able to deal with that pretty quickly. Because I don't want to deal with it on 2, 3, 4 visits if the person doesn't want to get better, or if they're scared to move in the first place. Well, I know I have to probably treat that person a little bit differently. I kind of have to find a good common ground with them so that they trust me. Because we're all trying to build trust with our patients at the end of the day. The more they trust you, the more they like you, the more if you give them things to do, especially when it comes to exercises and rehab, the more they're like, okay, yeah, I think I can do that. But you have to you have to work with them. So I always try to find what's going to get them to that next kind of level. So I'm always getting a sense of what they want out of treatment pretty quickly on. And then this is what we do in the middle, right? We work on, breaking up scar tissue, or working on their stability, working on their flexibility, doing our treatment, acupuncture, soft tissue, whatever it is, we're helping, we're here in the middle. And then where we're trying to get them is here. We're trying to get them back to work, back to life, back to activities, back to performance. I always get this wrong, but what is it? The height of our peak is only as tall, or is only as wide as our base, right? So if we're not good at the things down here, we're going to have a really, really small kind of height of this up and through here, right? So build this, we can do this, we're good at this, and then we can get them here. But if we're not, that's why I have like a whiteboard in my office, and I have written up there, it says self-care. And the first 3 things on self-care is nutrition, sleep, and mobility is what I do, because I feel like most people don't move enough. But I tell people every single day, like, if you're not doing your homework, there's no way my stuff's going to work. And I just put the ball in their court all the time, because then I don't want to be blamed for something that I know works, because I've helped too many people. But if it doesn't work for them, it's probably because they're not doing their homework, right? So I'd rather put the blame on them first, so that they're like, oh, crap, like, yeah, I don't want to disappoint him, And I'm like, great. That feels kind of cool, So they don't want to disappoint me. I'm like, cool, you do your stuff. I'm going to do my stuff, and we're going to get you to where you want to be. And it works out just fine. So always knock that out in the beginning. It makes life so much easier. So the very first thing that I do whenever someone comes in with pain, right? We're trying to move them from pain to performance. So the first thing I'm going to look at is, where is their bias when it comes to flexion or extension. What I mean by that is, when a patient comes in and they have lower back pain, are they flexion tolerant, which means they can go down, or they have a flexion bias, means that they rather go down, they rather flex their spine. If they do that and they have no pain, then they have a flexion bias. They rather go in flexion. If they have an extension bias, then they have no back pain, or they can go into extension and they have no issues. So I'm going to look at that the very first thing that I do. If someone reached down to grab, something out of the dryer and they hurt their back, they're probably not going to want to go into flexion, because that's how they hurt their back. So they're not going to like going into flexion. So guess what? I'm not going to give them any exercises that go into flexion. How many people say stretch your hamstrings because you got lower back pain? Well, what if you have a flexion intolerance? What if you if you go into flexion, your back hurts? Yeah, but my PT says I got to stretch my hamstrings. Well, you're going into flexion, and that's hurting your back. So that patient doesn't want to go into flexion. So when I design, or when I tell them what exercise I want them to do, it's based off, do you like flexion or do you like extension? And if you don't like flexion, there's no way that I'm going to put you into flexion, because we're just going to keep on irritating things. The spine may be a little bit sensitive right now to flexion. It's not like we're never going to get them back to being able to bend down and touch their toes or stretch their hamstrings. Just at this moment, they don't like flexion, or maybe they don't like extension. So one really interesting thing, and I'm sure we've all seen it, how many people come to our office and they say, oh, if I've already done physical therapy, I've already been maybe to the chiropractor, now I'm going to try acupuncture, right? And you're like, yeah, okay, finally, they came, right? They're the last resort. I got to fix this person, kind of thing, which is fine, but what happens when I see them is, I'm like, okay, you went to physical therapy. I always like to know, because remember, I worked at a physical therapy clinic for almost a year, and I'm always interested. Since I give so many exercises, I'm always interested in what exercises they already got. I'm actually really interested, too, in what the last chiropractor did and what the last acupuncturist did, because, again, at the end of the day, I don't want to do the same thing. Right? They're going to be like, what the heck? That's what the last person did, and I didn't get results. So I have to be different. So I kind of want to know what the other people did, so that I know not to do the same thing. I don't think my needle's shinier. I don't think, my adjustment's better. I don't think, the way I showed an exercise was better. I don't think that. I don't think I'm at that level, right? Now, of course, there's little things here and there, but I need to look at the body in a different way. So whenever I asked them what exercises they did, for lower back pain, it was always the exact same exercise. It was always cobras. Every single person came in and I need to do cobras. Or it was the other one, and it was I just need to stretch my hamstrings. But I was like, my gosh, why is everyone doing cobras? That's like the one exercise that everyone would do. And maybe it got super popular in yoga, and I don't know. So anyways, then I started to look into like, why is everyone doing cobras for lower back pain? Well, it was really interesting. There's this one physical therapist, and you may have heard of him. It's called Robert McKenzie. Have anyone heard of like the McKenzie technique? Yeah, and the McKenzie technique is amazing. I'm not knocking that technique. I think I want to take classes in it because I think it's really interesting. And I thought it was a really interesting story of why the McKenzie method became super, super famous or popular was because, so this Robert McKenzie's very, very famous physical therapist. And one day in clinic, he was super busy. And this guy comes in with like insane lower back pain, shooting down his leg kind of stuff, probably ridiculous kind of pain. And this Robert McKenzie, he was super busy. He said, hey, I'll get with you in just a second. If you can go into the other room and just lay on the table. And the guy said, okay, so he goes, lays on this table. And then it was like, by the time like Robert McKenzie, the PT, could get to him, it was like maybe 30 minutes to an hour. It took a long time, but, so he finally got to him. And he walks into the room and he looks at the guy, and the guy's on the table face down on his stomach, but someone forgot to put the table down. So the table was like this. When you can lift up the headrest and you can lift up the feet? So he was laying on it like, like a banana. And so this, McKenzie walks over, oh my God, like, how are you laying on this table like this? And the guy's like, he fell asleep. The guy gets off and he's like, man, my back's never felt better. He said, this is the most amazing treatment I've ever gotten. And he was fixed. Like no pain down the leg and no lower back pain, completely fixed. So this McKenzie was like, what the? He's like, oh, good, So anyways, of course, this prompted him to be like, what was that, right? And what they found is this person most likely had a flexion intolerance, could not bend forward, and an extension bias. So he wanted to be an extension. So that's what he got. He got extension. And what they found is with extension, it reduced the kind of like intradiscal pressure probably from on that nerve root, because they found that if you go into extension, then your disc pressure is going forward away from the nerve, right? That's probably getting pinched. And since he was an extension for that long period of time, it took that intradiscal pressure off of that nerve, and it fixed his lower back pain. So pretty cool way of finding things. Sometimes that happens, right? But from that became the McKenzie method, which is probably the most, honestly, probably the most taught thing in all PT programs now. And that's why every physical therapist gives Cobra exercises, because it's just purely extension exercises. And they do it repetitively, and it's like a ton of reps. I'm talking about 80 to 100 reps. They want you to do a lot of them. It's not like you just do 10 press-ups. It's a ton of press-ups. So, and again, every single person that would come to my office that failed physical therapy, they'd be like, oh, they just gave me press-ups kind of thing. And I was like, okay, I can't just give you press-ups, right? We got to see what else is going on. We got to see if maybe you actually have a flexion bias. Maybe you don't need to be going that way. Maybe you need to be going the opposite way. So this is where I kind of start with my assessment when they first come in the office, right? So this is kind of a blueprint. It can look very daunting right now, but we're going to break this down. This is just the chart that I use. And again, if you look up here, it's still our pain to performance chart. But when they first come in on their first visit, I'm going to be looking at just these tests that are up here, the hip IR, Thomas test, the thoracic rotation. I'm just going to be looking at that. And then when we get into flexion, are they flexion biased? Do they like going into flexion, or do they like going into extension? That's it. For right now, that's all you have to know, and then I'll break down this chart with you. But this might be a really good blueprint for you to use when you're back in your practice of where to start. Because a lot of times that's difficult, right? We don't know where to start with exercises. So let me see what the next slide is real quick. Okay, perfect. So when I first start with the patient, again, remember, just like we all do, just like Jamie did, just like Anthony did, when we're doing XSTOR, we're looking at range of motion. Super important just to look at range of motion. If I'm looking at range of motion and I'm just assessing flexion or extension, I already know, do they like it or they don't like it? And we'll go through that demo. Remember when we talked about the joint by joint approach and we talked about we got to look either above or below? If they're having lumbar spine pain, I'm going to look above or below. So I'm going to look at the hip because that's what's below the lumbar spine. Or I'm going to look above, which is the thoracic spine, right? Because if we're not moving well from our thoracic spine and we're not moving well from our hips, then our lumbar spine is probably becoming like an energy leak. Now it's having to move more because of the other areas that aren't moving well. So we're going to look at the thoracic spine and we're going to look at the hips to see how they're moving. Because if they're not moving well, yet they're supposed to be the more mobile joints, then that's possibly why our lumbar spine is unstable. Okay? So we do this all the time. How many times do when we lay a patient down on their back and we move their hip into internal and external rotation, right? What are we checking there? Are we just doing it for fun? We're just doing like this for fun? Or are we actually testing something when it comes to their hips? We want to see, do they have at least 40 degrees of range of motion in their hip internal and external rotation? If they don't, then we want to get their hip more mobile. We want to maybe give them some stretches to open up their internal and external rotation of their hip. We know how tight people's hips are, right? It's just all the time people come in, my hips are tight, my hips are tight. If that's causing the lower back pain, we'll test, do they have at least 40 degrees of internal and external rotation of their hip? If they do, okay, then we can move on to the next test. We're going to do the Thomas test. All these tests are going to be shown to you. Okay, we'll get a massage table up here. And then we're also going to test, so the Thomas test is for the anterior hip. So for like the hip flexors, iliacus, psoas, and then the rectus femoris. If they're super tight in the front of their hip, we know that maybe if they're having tension in the front of their hip, that could be pulling on their lumbar spine, right? Again, we can't just look at the low back right now because that's what everyone's doing. We want to start to look like, are the muscles in the front of the hip super tight, tugging on their lower spine, causing some instability, causing some lower back pain. So we're going to look at a Thomas test. The next thing we're going to look at is thoracic rotation. And I'll show you how to test for thoracic rotation. But if we aren't rotating well through our thoracic spine, if we don't have at least 45 degrees of range of motion in our thoracic spine, then our lumbar spine is probably having to rob motion to get that last little bit so that, and it's making it unstable in that lower back. When someone has to reach, let's say reach behind them like this, and if they're a super kyphotic person, right, they sit at a computer desk like this all day long, and they don't have any motion from their thoracic spine to be able to reach back like that, where do you think they're going to put their motion into? They're going to arch their back to do it. Because they can't arch their mid-back to do it. They don't have that ability to do that. So they're going to use their lumbar spine. And they do that over and over and over, and then they wonder why they have lower back pain. But it's not their lower back's fault. It's actually probably coming from the thoracic spine. So I'm not looking at the lower back. I'm not looking at doing, let's get you right into doing planks. Let's get you right into doing, any core exercise, even though we know core is a very good, strong feature to have. But it's probably coming from either the hips or it's coming from the thoracic spine. So that's where I go through first, okay? So I'm going to demonstrate. So from this position here, this is part of my X-Dor scan anyway, right? So I'm already coming up and through here. I'm already kind of going through hip IR, ER. Sometimes I just do this just to kind of assess just gross range of motion. How fluid is their hip, right? I'll go through here and just see how much mobility they have through their hip. But then once I'm here, I'm bringing it in or I'm bringing it out. This is internal rotation. This is external rotation. If they start complaining of, other hip stuff and things like that, I'm not really concerned about that right now. I'm really just seeing how much range of motion they have from side to side. Then I'll do the same thing on the other side. Now, if I'm already doing X-Dor, I know a lot of people here are doing it, I can just note that to keep your leg up just like this. Go ahead, push up into my end. Perfect, okay. And then I'll continue on with the rest of my testing. Then when I'm on this side, I'll do the same thing, right? I'll just bring it up. I'll assess this way, this way. Now we can see a little bit more, a little bit harder on this side. Okay, and then go ahead and have a seat for me. So easy to assess hip, internal rotation, and external rotation. Then we're going to do the Thomas test. I'm going to have you just have a seat on the edge of the table. Good. Scoot up just a little bit. Perfect. Then what I want you to do is grab your knee with both hands and then go ahead and lay on back. So this is called the Thomas test. What I'm looking at it for the Thomas test is we're looking at anterior hip tightness. Now you see his knee is completely down in terms of like his hamstring is completely flush with the table. If he had tightness in the front of his hip, exactly, he'd have his knee up like this. If his knee up is like that, maybe he's got tight quads. Maybe he's got a tight hip flexor. Maybe he's got a tight psoas, right? Go ahead, drop that down. Now, also, sometimes I'll just take the bottom of the foot and I'll just kind of push it back like this too. And if he can't do that, then he's probably super, super tight, right? I kind of maybe have to look a little bit further down the chain. If he's doing this, when it comes out to the side, you know what that is? That's super tight IT band. So if someone comes in and I have an IT band, all my PT told me I got an IT band syndrome. Okay, let's see. Lay him down on the table, do a Thomas test. If they have a result like this and they tell me they have tight IT band, I'm like, no, you don't. You don't have, look, your IT band is completely relaxed. Everything is super relaxed. Your foot's completely flush with the table. So again, this is going to be a negative in terms of this is they failed the Thomas test. They have super tightness in the front of their hip. This is a pass. So for our blueprint, we'll go back to it, but this means I don't have to work a ton of mobility on the front of his hip because he's fine, no problems, okay? And then you can switch. You can have him grab that knee. Some people can't grab the front of the knee, have them grab the back of their knee. Okay, super easy. Yep, just like that. Same thing, super flat with the table, not a lot of tightness through the front of that knee. It's not going out to the side. I'm not thinking it's going to be IT band. He's fine. Okay, so that's the Thomas test. Okay, go ahead, come on up. And then I'm going to show you the thoracic rotation. So for thoracic rotation, go ahead and go up on all fours. Good. Now for this, remember, we don't want the lumbar spine to be involved in this. So we're going to have to lock out the lumbar spine so that it doesn't do anything because we purely want as much thoracic rotation as possible. So what you're going to do is you're going to sit your butt back into your heels. Good. Then I want you to put your hand kind of like on the back of your head. And then from this point, what I want you to do, well, you can actually start like this. You're going to try to bring this elbow towards the ceiling. Good. So now I'm assessing how much thoracic rotation does he have. I want it to get to 45 degrees, right? So he can bring his elbow all the way up to the ceiling. That looks perfect. Good. Then you can bring it back down. Good. And then try the other side. Good. So we're assessing pure thoracic rotation. And if he had a limitation, let's say you just can only get to about right here, well, now he probably isn't getting good thoracic rotation on his left side. I'm going to give him exercises to get better thoracic rotation through his thoracic spine. Now, this is what I see every day. He's good, right? I shouldn't even use him as an example anymore. But we're going to do this, as a class later on, and we're going to see this a ton. You can go ahead and relax. I see this even more so, and I know this is, again, low back rehab, in a ton of neck and in a ton of shoulders. If people aren't rotating or extending well through the thoracic spine, they're compensating, and then they're not getting the proper stability into their shoulder because they just don't have the range to move, right? Because, again, we got to look at, and you can have a seat for me, what do our patients do for most of their day? They're generally probably sitting at a computer screen, so they're super kyphotic. So they don't have the ability to extend through the thoracic spine. Another thing what they're doing, they're sitting. So their hip flexors are always pulled up like this, and they're always sitting on their butt, which is tightening up their hips. So it makes a lot of sense why someone has tight hips, tight T-spine, and then lower back pain. If they're not moving well through the thoracic spine, they're not moving through their hips, or lower back, it's just waiting to get it. So that's where I start my assessment, T-spine and hips, okay? Thanks. So the question was, what if it's hard for our patients to get into some of these positions, right? So we modify, right? Like if you have a patient who can't get on all fours, so you could still do this from a seated position as well. Hopefully everyone can see me, but pretty much like I'm going to be seated. We don't have to start the demo back up, but you can just drop one arm down and see if they can just reach up. Well, you're still getting thoracic rotation doing it this way. If they can't do that, then just do this, right? Like you're still going to get at least a little bit of like, because you want to get them there eventually, right? Your goal, now if they're, have a bunch of joint replacements and they just can't do it, again, they can at least do this, right? And then you'll do treatment, and if it gets better, then your treatment worked. So there's lots of modifications for it. You want to know about the other ones too? Yeah, the thoracic rotation, yeah. Seated. Easy. Yes. Hips are easier to assess, but the thoracic spine, either this way or just down like that and try to reach up towards the sky and then back down, okay? But it's a big one. I'm telling you, I prescribe thoracic rotation exercises every single day, and it's for lower back pain too and for neck pain, because if they're not moving through the thoracic spine, then they're using the lower back. Something's going to have to move more, and it's going to rob it from the lower back, especially when it comes to the golfers, because they are already twisting. And so if they don't have that rotation, it's going to extend from their lower back. So I like this quote: "If I've seen further, it is by standing upon the shoulders of giants." You know who my giants are? Well, Anthony's actually really a giant because he's actually like really tall. But Jamie Chavez, I mean everyone, right? And I've taken so many courses, and none of this is I didn't make this stuff up, right? This is stuff that's been researched. This is just stuff that's kind of been compiled. And it's really helped me to get results with my patients. But we really just have to, when we take so many courses, and I think even Jamie said this the other day, like big toe flexion, right? Like we can go crazy of just looking at the foot and saying that's why our low back hurts, because we have no big toe ability to move our big toe. That's so specific. That's so minute. And there's probably some power to it, and there's something to it. I believe in it. But that's why we have to take all the courses that we're doing and just figure out what works for us. This is just what worked for me. And this is why I'm giving it to you guys, because it's purely just what worked for me. Yeah, go ahead.
Going off of what the other question was, I was curious about the Thomas test, because if I had somebody in acute low back pain with sciatica, this doesn't, I don't know, I don't feel comfortable
testing
that.
Yeah. So the question was, the Thomas test, when we're sitting on the edge of the table and we have to lean back and we're grabbing our knee, if we have someone that's super flared up or sciatica, right, something that you just don't feel comfortable with them doing that position. Sometimes you just don't have them do that position.
There's no modification. Or when he was lying on the table already down,
yeah.
You put them down and
sure.
Out the movement?
Yeah, you could just assess if it's super tight, like you could have them do this. Right, and if it does come up a little bit, it could, maybe a little bit. But if they're super flared up, I'm probably not going to be doing a whole lot of testing like that, right? I got to calm it down first, and then as things calm down and they can get up and move a little bit better, maybe visit 2, 3,
I'm curious how much the movement mattered versus if they were already on the table and then just lifted their legs.
Yeah. You can modify it. Yeah. Now, if they're already on the table and they feel comfortable with going back like that, then do it. Yeah. But it is a really good way of assessing, what's going on in the front of the hip, because a lot of times people come in oh, I'm super tight through my hip flexors. I hear super tight through my hip flexors. Tight. I'm just tight. Everything's tight, right? We'll test it, and then you can explain to them well, actually, this is not tightness. This is actually, you're doing fine. You probably have other things going on, which is great to educate your patients on what else is going on, because they've already proved to themselves using Google and Instagram what they have, right? They already told you what they have, because, they looked up top things for the runners, and every runner's got tight hip flexors. So they already came in and told you that they have tight hip flexors. I love to prove people wrong, not because I just rather them know what they do have, because then they start working towards what they should be doing. So then the exercises really work, and they stop stretching their hip flexors, for crying out loud, because that's not the problem, So I do Thomas test every single day, especially for the people who tell me they got tight hip flexors, because I'm like, okay, well, if it was tight, your knee would be off the table like this. Your knee's completely flush with the table. There's no way that that's tight. If anything, it's probably weak, you know? And like no person likes to know that they're weak. But then if they work out, then they're like, okay, cool. So tell me what exercise I should work on. And then they do it. And it's not like physical therapy where they did the same, you know, Cobra stretches and everything worked, right? So, do you have a question? Sure. So the question was, for the dancers that I treat, a lot of times they're super flexible, right? So how do you assess someone if they're super flexible but they still complain of tight hip flexors? You can still do the same test. The test is still good, right?
Their leg would be like.
Yeah, sometimes their leg is still like that, but they're still complaining of tight hip flexors, right? Again, I'm looking somewhere else. Because how long have they been complaining of tight hip flexors? If it's like they've been, my whole life I've been tight on my hip flexors. Well, then let's see what else is going on. How well do you extend your hip? Are you using your hips actually the way they should be using? Are you're using your glutes? Because a lot of times I'm finding that they're not actually extending through their hips. They're just overusing the hip flexors, right? Because they are doing this a lot, but they're not training other parts of their body. They're just dancing. So they're not really doing any other exercises to strengthen other parts.
So maybe they have like an injury in the hip flexor, they have discomfort there.
Yeah.
Or a relative right to left type thing.
Yeah. Could it be an imbalance?
That's not a tight hip flexor.
I don't think a tight hip flexor is a true tight hip flexor. I think it's just a sensation that people feel. They just feel tight. But then when I start telling them, okay, what I want you to start strengthening things, then they're like, oh, that sensation went away, right? Because we have to change things now. Because every dancer that I've seen, they can do incredible things. They can bend all the way backwards, right? And when they stretch, they go to the very end range. Everything is completely end range stuff. We have to start strengthening other muscles, and we need to add in control because they tend to get injured a lot. Dancers get injured so much. I mean, great for business, but it's like terrible on their bodies. I mean, I'm like, gosh, they're always a wreck, you know? And it's like everywhere, you know? They're getting beat up so bad. I mean, like, you know, I treat soccer players, like professional soccer players. The dancers have more injuries than the soccer players. So with dancers, I got to be careful because they just like to stretch. They just like, all of them are just like super bendy wendy and like they all want to stretch. And then I have to tell them, I'm like, no, like you're going to have to start to strengthen. Like you have to. Because like sometimes I even think maybe like their ligaments are maybe a little bit more lax. I don't know. Like I can't put any research on that. But I feel like they're overstretching. And if they added a little bit of a strengthening component to it, I think they would help out.
And once they've overstretched like that, they get pain.
Exactly.
They don't maintain
Yep.
that in a balanced way. So it becomes kind of like a lifelong.
Exactly. Yep. I think they just overdo it. They're just so used to being so stretchy that they don't know how to get out of that end range kind of stuff. So I have to start saying, nope, you got to start lifting a little bit. Not like heavy weights, but some kind of resistance training I think can go a long way. Yeah. Did you have a question?
There was the head of the Charleston Ballet Company in South Carolina, and my children took ballet from him.
Oh, wow.
And I mean, he was well known, famous in Charleston,
Mm-hmm.
and you should have seen him in his older years. He had the worst arthritis.
Yeah. And, you know, so the question was, there was a famous ballet in Charleston, and in his later years, he had a lot of arthritis, right? So, again, like, we want to catch it early, right? And then stop stretching. You know, if that's all they've been doing, again, I'm going to say the opposite. But I'm still going to do my tests. And if it's truly tight, then of course I'm going to tell them to stretch. But most of the time, they're not tight. And how many times do we hear that a day in our office? Tight. I'm just tight. Okay, like, you know, is it truly tight? Or we're just not looking where we should be. And that's why I started to do more rehab, because I was like, I can't keep on just needling this or gua shaing this, or like I got to start looking somewhere else too. Okay, so super simple test that you can do to evaluate things. Okay, so finding your bias. So remember, this was the very first thing that I did. I want to know, is that person flexion bias or extension bias? Do they like going into flexion? Do they hate going into flexion? Can they tolerate going into extension? Do they like going into extension? And we can dumb these down in terms of what I mean is like progression or regression. If they're coming in with a ton of pain, maybe they can't go all the way down yet. Maybe I have to bring it down to just the child's pose. Maybe they can only do it from a seated position. honestly, if someone's coming in super acute, they can't even really lay down on my table, I can't really do an assessment, well, then maybe their exercise is literally either flexion or just extension. So if they come in and they're like, oh, my back's, I can't do that. Okay, I'm like, okay, can you go backwards? And they go, yeah, that's better. I can do that. Okay, perfect. I'll still do treatment, right? Whatever I do, I'll do something. And their home exercise is literally prone on elbows. Just from here to here. And if they can do that, perfect. That's their exercise. If they can't do that, then they'll go up to a wall. I think they can see me. And they'll just kind of go from the wall, and they'll just bring their hips back and come forward. It's still extension. You're still getting extension, right? So if they can tolerate just some extension, I'll just tell them you're going home, and you're just doing a ton of those. And then I want to see you in a day or a couple of days. And then they come in, and since that was they could tolerate extension, they always have a little bit more motion now. So usually we've calmed it down, and then we can then say, okay, well now we're going to go to your elbows, now we're going to go prone press up. So you lay on your stomach, and then you can do cobra, right? And then you can actually tell them to do a cobra because it's giving them extension. Then from a prone press up, if that feels good, then you can do prone press up with overpressure. Honestly, I do this very seldomly in my office, but what that means is you can take like one of those resistance bands, you can kind of wrap it around your hand, put it down to where it's kind of pushing into your lower back, and then that overpressure is on your lower back, and then you're doing extension, and that little overpressure is just adding a little bit more extension into the lumbar spine. So you're just getting a little bit more of that overpressure onto the spine. Then we're going to see if they can do asymmetrical standing extension. Asymmetrical just means that we're offloading one leg and we're going into extension. If they can do that and they can bear that and there's no pain, then they can do that exercise. But this is a way of finding your bias too. If someone's really, really kind of a hot low back or in a lot of pain, and let's say you want to see if they're flexion or extension, you can first start them with just on their stomach, and you're pretty much just on their stomach like this. If they say, oh, I got a ton of lower back pain in this position, well then let's see if they can go into child's pose. If they go like this, like, oh yeah, that feels so good. That feels so much better on my lower back. That's their exercise. Or that's just me finding their bias. Means like, okay, they like child's pose and they hated prone on elbows. Well then I'm sticking with flexion bias. That's what they want. So I know that I'm going to give them any exercise from here on out. I have to respect the bias, which means that I have to only give them exercise that they're going to like flexion and really stay away from anything that's going to give extension. Okay? And then I'm always asking, okay, which direction is easier, stronger, without pain, with pain, better quality? That's just how I know it. You know, do they like forward or do they like backwards? That's it. So demo, kind of what I just said, you know, with flexion, we're just going down towards our toes. We can do the child's pose. Seated flexion, you can just have them seated. You're just having them flex down. Does that feel better? Feels better. If that doesn't feel good, oh, nope, that hurts my back like crazy, not doing it. And then just standing, it's either you just take one leg off, you go this way, if that feels good, good. If they can go like this, again, that feels fine, no pain, they like extension. To be honest with you, most people hurt their back. From my experience in my office, most people hurt their back by going flexion and rotation. That's how most people injure their back. So most of the time, or a lot of times, I'm giving a lot more extension exercises. So PTs were right, you know, in terms of like they're probably just going with the 80%. You know, they're like, well, 80% of people hurt their back doing it that way. That's probably why we're going to give them all extension exercises. But a lot of people usually hurt their back going some kind of flexion and rotation. So that's why I think extension exercises are just used so commonly. Cool. So any questions? Okay, we're doing good? Hopefully. Okay, so, and then we have so this is another assessment. Again, like the more we can assess, the more we kind of know about our patient. We all know, gosh, I'm flying through this. It's already 5:30. Basic motion assessment. Cat-cow. Everyone's heard about the cat-cow, right? Everyone thinks it's a really good exercise, but what is it really showing us at the end of the day? Cat-cow, it's also a way of getting flexion and extension into our lumbar spine, right? Because we can sag our lumbar spine into extension, or we can flex our lumbar spine. So it's a good way of knowing, is my patient flexion bias or extension bias? But a lot of times when I give people the cat-cow, they cannot move their lumbar spine. They actually go like this. They move their upper back or they drop down their upper back. And they have no control over their lumbar spine. I'm like, no. I want you to move here. And they're like, I am moving there. Am I not moving there? And I'm like, no. Like, you have to move from your lower back. And they can't do it. And that happens a lot. And it's because a lot of people don't have the ability to, again, disassociate their hips from their lower back. So it's a really good assessment to see, can they actually move their lumbar spine? Can they control their core to get them into those different positions? Because if they can't, if you're going to throw them into a plank and they have no control to even keep their spine in that position, they're probably going to be sagging that spine, creating too much extension, and then they're going to be causing lower back pain. So I like the cat-cow, but I first have to assess if they can even do it correctly, because if they're not doing it correctly, again, it's the number one exercise if you look up 5 best yoga stretches for low back pain. It's on every single yoga top list for lower back pain. But people don't do it correctly. So they're going to come into your office complaining of lower back pain. So assess it and be like, no, you're not moving. And then it's really nice. What I usually do, if they don't have a lot of pain, I just tell them, well, put your hand on your lower back. And then I just want your hand to go down and then your hand to come up. So I want them to feel their hand kind of dropping down. I also have to cue them sometimes on like tuck your tailbone forward or tuck it back. So again, they're getting more hip mobility out of it, and they're using their core to bring them in there, right? And then they actually have the strength and stability to do it from their spine, and they're not just rocking their upper back to get it done. So I do like cat-cow, but I just feel like it's not used the right way, okay? I feel like I need to fly through some of this stuff. So, okay, good. So, and then we assess above and below, right? Hip, IR, ER, Thomas test, thoracic rotation. If it was more than 40, then we can start to move them into more of like the strength category or the speed or the power, right? Thomas test, is it positive? If it's positive, they're not ready to go into strengthening or progressing through there. All right, so we're going to go back to just to assess. We're going to go back to saying, okay, are they better at hip, IR, ER? Are they, how's their Thomas test? Is it positive? Is it negative? How's their thoracic rotation? Those are the first 3 tests that I do. Then we move into, so those are the tests, right? We can do the hip, ER, IR, Thomas test off the table. This is a good one still, active straight leg raise. I throw this into every lower back pain one. Really, because also, remember when I talked about the fascial sling? Well, like, that's still wrapped into the lower back. So am I giving them like a hamstring stretch? Am I assessing how much hamstring mobility they have? No, I'm not. But I still want to know how much tension they have. If they have sciatica, if I'm assuming radiculopathy or anything like that, I still want to know what's their posterior fascial sling or line doing. So I still test that active straight leg raise. And then thoracic rotation, of course, I'm testing that as well. And then we're going to go into the mobility. So how do we get our hips moving? What are the most beneficial stretches to get better hip ER and IR? When we're assessing above and below, that's the first phase. Benefit, indirect intervention for a sensitive spine. So they're coming in with lower back pain. I'm not going to give them lower back pain exercises because right now their lower back is sensitive. So I'm not going to push into pain. I'm going to calm things down and work on things above and below. That's why I'm working on the hips, where I can work below. That's addressing the root cause in an overuse injury, right? Because we're pretty much saying that the lumbar spine is getting overused in this case. It's getting unstable because the thoracic spine and the hips aren't doing their job. So that's why the lumbar spine is not the root cause. It's not the source of the problem. It's actually above or below. Pain-free movement options to encourage a positive mindset. This is huge. Remember, our patients are scared to move. They're in a ton of pain. I'm not going to give them any exercise that's going to cause pain. I'm actually going to give them an exercise that they're like, wow, this feels really good. I'm like, great. If it feels really good, I want you to do it a lot because it feels really good. And then they're motivated to move more. And if they're motivated to move more, then they have better outcomes at the end of the day to getting back to doing what they were doing before. But if I give them something that's hard or something that's painful, they're not going to either do it or we're only delaying the process of them getting back to doing what they were doing before because they're fearful of doing it. So all these exercises that are super complicated or super complex, and you gotta get into this position and you gotta breathe into a balloon. Again, I have nothing against some of these things, but sometimes it's really complicated and patients just aren't going to do it. So my goal is to give them something super easy. Sometimes I just tell people, just go for a walk. That's it. I don't even give them any exercise. I said, how's walking feel? Oh, I love walking my dog. It feels so good on my back. Perfect. That is the only rehab exercise you're getting. And I'm like, do that, don't do a crazy amount, but go walk, feels good, then go home, rest, and then I'll see you in a couple of days. We're still doing our thing in the office to get pain management control down, but at least find something that they enjoy doing because it's just gonna get them better faster. Because most of the time they think they're supposed to rest. They think they're supposed to go home, put a heat pack on it, and just not do anything. Nope. I want them moving as soon as possible. And I encourage them to move. Unless there's so much pain, moving hurts. But generally we can find something that feels better. So if you can find that the first visit, that's always their homework. If you want to get better at something, practice it a lot. This applies to all facets of life, but when it comes to exercise, most people, they're like, I did it 3 times, I did it 10 times, and then I stopped. They only did it 1 time that week. Exercise is probably the least compliancy ever. It just sucks, Sometimes it's that's why I got to find what feels better. And I got to get them to do that because then at least I know they're going to do that, right? But if I give them bridges or, planks and they are already somebody who never goes to the gym and they could care less about exercise, they're not going to do it. So I got to find something else. I'm like, okay, do you like going on your bicycle? Do you again, walking is an easy one, but you got to find something that they're actually going to do. So again, they got to do it at the end of the day. And if they don't do it, again, I just put it on them. I'm like, listen, my patients who get the best results are the ones who do the exercises. The patients who don't get the best results, they don't really get the results because they're not doing the exercises. So it's up to you. If you come in and you didn't really get the results that I thought you were going to get or you thought you were going to get, it's probably because you're not doing something. And then they're like, oh, yeah, I didn't do them. And I'm like, okay, well, it's your money. It's your time at the end of the day, But if you really want to get the results, do these exercises. These are and I always make it like this. I'm like, these are the best exercises. These are the most researched exercises. These are the most effective exercises. And if you do these exercises, you're going to get better. But if you state it like that, again, you're just building your value. You're building why you're even doing this. Why are you even telling them to do this if you didn't think it was going to do anything? Otherwise, just tell them to go look it up on YouTube. But we all know that's not going to work. So I just tell them, listen, I'm going to find what's actually going to work for you. But if you do it, that's when you're going to get the results. If you don't do it, we'll see. So then the compliancy goes up. That's the only reason the compliancy goes up with me. Because I used to give a lot of exercises. No one would ever do them. So then I'm just I'm just going to keep it so simple. And then I'm just going to put it all into their, put the ball in their court and be like, okay, it's up to you. And then the compliancy went up. So I recommend doing it that way. And then modify the position to achieve pain-free experience, right? Again, not everyone's going to be able to do all of these exercises. So just figure out what works for them. If they can't get down to do a cat-cow, well, there's a million ways. You can do it standing. You could do it sitting down, right? You're still doing it, but you're just doing it in a different position. If that's what feels good, then, again, modify, but it shouldn't be difficult. Mobilizing the thoracic spine. So this is how I would, if I found that the thoracic spine was not moving in 45 degrees, a couple of things that you could use. You can use a foam roller or something like this, right? Everyone's heard of a foam roller, right? So foam roller, you can just put it in your kind of back area, and you're just getting some extension out of that thoracic spine. Just moving through that. If someone doesn't have a foam roller, you can do other different ways too. Sometimes I just show them, let's say they're just like an office worker, and they need to get thoracic rotation and extension throughout the day. Then I just tell them to put, you can't see me? What about here? So I tell them to just put their elbows onto a table like this, scoot their hips back, and just get that extension throughout their back. Right? You can do it that way. Or if the back is somewhere where they can put their back here, we just put this just like this, just like that. And we're getting some thoracic extension. The one before is we put our elbows on the table, scoot our hips back, and then we're just sinking our thoracic spine down and then bring it up. It's almost like a cat-cow for our mid-back, right? So that's how you can get mobility out of your thoracic spine. Or a bench or an exercise ball. Again, like if we think about it, we can pretty much do this on anything. We can use a table to do it as well. We're just trying to kind of just get extension throughout this mid-back. And I give this one to a lot of people if they're office workers, because again, you got to meet the person where they're at. So if they're at work for most of the day, when are they going to do their exercises? We'll show them how to do it at their desk. And that's so easy. Thoracic extension is easy to do from the desk. The other one is thoracic spine rotation. So for rotation, same thing. If they're an office worker, I'm just sitting down. Either I'm going down like this, right? They're getting some rotation. And this is good for an office worker to move anyway because they're just getting super stiff, right? Or I'm going the other way. Just like that. I like to sometimes put my hand on the outside of the knee. You'll get a little bit more. Just like that. All right, so that's good. Or the quadruped, that's when we're on our side, or just same position Moses was in. Bringing it up, bringing it down. Maybe 10 reps, okay? Just like that. And then this one I like a lot because everyone loves this one because they probably learned it at yoga somewhere. So this is when we're laying on our side and opening up, right? Everyone loves that one. So I give that to most people because it just feels good. Again, if it feels good, they're probably going to do it. If it requires even a foam roller, it's like asking them to give you their firstborn child. I'm like, just get a foam roller. They can't do it, you know? So again, I just find what works, and I find that the sideline rotation is the easiest. Mobilizing the hip. So if we found tightness or limited internal, external rotation of the hip, we can foam roll the hip, right? We can use something like this. You've seen the foam ones too. We can foam roll the front of the hip where we're just laying on it and just going up and down on the front of that hip, right? Just kind of that one sucks. We can also do the half kneeling one. This is probably the one that I probably show the most, but it's when we're kind of in this half kneeling position like this. I always tell people you got to take those hips, you got to tuck the tailbone forward, squeeze the glute on that same side, and then from here we can kind of go forward. We're going to get that stretch, and I just keep it dynamic. If they tell me they have some tightness in through here, again, I'll tug that hip forward, bring it up, bring it over. 10, 20 reps. They're going to feel looser in through here. Okay, so that's one way of getting the front of the hip to release or relax. And then do your Thomas test. Retest, right? So see, did you make a difference? Half kneeling, hip flexor stretch, grab ankle, quad stretch. So if someone can't get into that position, right, can they grab the back of their knee and just hold a stretch? If they need a little bit more, maybe they can get here like this, move forward, and again, just drop down like that. Again, they're just getting a stretch through the front of their hip. So lots of different ways to do it. As long as they're doing something to address the tightness in the front of their hip, they're going to help that front side. Posterior hip, this is again, maybe ER was limited. Back and through here, what we can do, pigeon pose. Everybody knows pigeon pose, right? Going forward like that. Really getting that to open up. Bretzel. This one most people probably don't know. Might be hard to show, but it's pretty much I'm just taking my leg over like this and then taking the opposite leg and bringing it down. Yeah. No one's going to do that one. So instead of that one, yeah, so you could really just take your hip and just bring it over. You're still getting this stretch. Again, just find what's simple. And honestly, most of the time, the one that I'm giving the most, you sit in a chair, you put your leg over, you sit up nice and tall, and you lean forward. You're going to feel a big stretch. And most people are like, oh, I can't even get there, you know? And I'm like, yeah, because you're so tight. You know, like your back is screaming. So, but the most important thing that I have to tell people, because most people are like this, you know, sit up tall. As soon as they sit up tall, it already puts such a big stretch on their hip that they don't need to lean forward. And most of them can't even lean forward. As soon as they go here, they're like, oh, they're already holding their breath. So you got to remind them to breathe, you know? And just do that. Again, people always ask this too before someone asks, which is okay, but how many reps, how many sets? Don't care. Just do it. I could care less. Because there's no magical number. There's no 3 sets of 10. I don't know who made that up. I hope they're rich. You know, because I don't know. Everyone says 3 sets of 10. I'm like, as many of you can do, you know? Like, don't go overboard. But, you know, every hour, if you're an office worker, stand up. Go over to a wall. Do a couple extensions. Sit down. Do this for maybe 5-10 seconds. Do it on the other side, 5-10 seconds. You know, do this 10 times. Do this 10 times. Go back to work. That took you 2 minutes. All right? You have a question?
Yeah, do you have a recommendation for a hip flexor stretch while people are sitting?
Yeah. So while people are sitting, if they can put a knee on the ground, the question was, how do you do a hip flexor stretch if someone is like a desk worker or sitting kind of thing, right? So if they have like a roller chair, it's easier, but you can do the same thing. You just take that leg and just bring it back behind you like this. So you're kind of on the edge of your seat a little bit, right? So you're still in that half kneeling kind of pose, or just do it standing. You can still do it. You're just going to stand up and do it, just like that. You know, or, you know, have something, you can use the chair, same thing, right? Just like that. So lots of different ways to do it. Use your chair. Use your surroundings around you. It should be okay. Okay, I got to fly. So reassess above and below. Patient does not need to be in green to advance the next phase. So like if they're getting close, you know, like you can start throwing in some other exercises. If they're getting better, like I'm probably going to, again, like how much pain are they in? You know, like can they start doing a little bit more walking? Can they start kind of going to swimming class? Like I don't want to take away their life like forever until like they get like perfect 45 degrees. Like I don't work with like perfect numbers, but like, you know, they're still a human being. So I'm still kind of getting them back to doing their activities a little bit at this point too. But these are their exercises at least. At least you know what to give them at the end of the day, right? Quick assessment. Again, they may get tight, right? They haven't moved in a while. So like, you know, sometimes you can expect a little bit of tightness, and then keep it simple. Just, you know, find ways that they can do it at the end of the day. So this is just another research article, lumbo-pelvic relationship. So is there a association between hip range of motion and nonspecific low back pain? So do the hips and the low back, do they talk? Well, this article shows that it does. And they found that hip and lumbar movements are intimately coupled during daily movements. Limited hip range of motion has been suggested as a risk factor for onset of low back pain. There you go. So we've got to get the hips moving to get our lower back pain patients moving better without pain. Stability, I only have 5 minutes. That's why I'm rushing. Sorry, guys. So stability, if I'm going to start, okay, so their mobility is better. Their hip range of motion is better. Their thoracic range of motion is better. Their hip flexor range of motion is better. Now they're ready for some strengthening. Because remember, I want to get them strong. I want to get their lumbar spine and core working better. That's when I'm going to start to plug in some stability. If they liked flexion, we can do planks. We can do shoulder taps. If they didn't like flexion, I'm not giving them a plank. So again, when people are coming in, like, I heard planks are good for lower back pain. Well, maybe not your lower back pain, because maybe you don't like flexion. So I'm not going to give you planks, even though you know that it's good for core. So that's why it's another reason to check what exercises your patients are doing, because they may just be contributing to their pain, okay? Extension, reverse plank, side plank, T-hold. Again, if they could hold it for 60 seconds, then you can start to go into some of these other kind of patterns in through here. But you at least want to see if they can do it for 60 seconds. Now, again, it's a hard number, but like, are you going to be testing everyone's like 1 minute planks in your office? No, but if they can do it for if this is something that they've already been used to, like your athletes that are coming in and they're going to CrossFit and they're doing all that kind of stuff, they could probably do it, So, but again, you just want to make sure you're doing it at the right time, because you just don't want your results to be swayed by something that they could be doing that's like interfering with that, okay? So basic stability, we've seen this before, front plank. So you can see he's in flexion, right? No wonder he likes the plank, because he likes flexion. So this is a good exercise for someone who likes flexion. Single arm plank is just a little bit more difficult, but again, he's in flexion. That's why his lower back pain likes it, okay? Reverse plank, if, this is someone who likes extension. So if someone who didn't like that flexion, they wouldn't like that exercise. Side plank, again, it's for somebody who likes extension. Basic flexion, tolerance, stability. If someone, likes flexion and I want to strengthen their core, strengthen their deep core intrinsic muscles, I'm going to give them a dead bug. Have we heard of dead bugs before? Yeah. So, and you can always Google dead bug, they'll show you how to do it. Crawl hold is pretty much he's in like this kind of holding position, and he's just tapping his shoulders. So again, he's flexion bias. He likes flexion. So you can start to challenge the core to get it stronger, because we want to get that core strong. Next is extension, tolerance, stability. This is when you've probably seen the bridge. Again, most people are coming in, they are extension bias in terms of they like going backwards. I'm probably giving a lot of bridge exercises. We're doing a lot of this exercise in my office, because this I also like, not only because it's helping the lower back, but it's actually strengthening the glutes, which we know how important the glutes are when it comes to lower back pain as well. So if we can get our glutes back on, and we can strengthen our glutes by doing this exercise, we're getting a 2-for-1. I tell people, actually, we're getting a 3-for-1. I really like this exercise because we're stretching the hip flexors. Everyone's favorite hip flexors, they like to stretch. They're also getting a little bit of stretch on the hip flexors. They're getting glute activation, and they're getting lumbar spine stability. So favorite exercise, bridge. I tell people to do it all the time. Reassess. Can they do it longer? Can you move to the next exercise? Can they move to now doing more activities? Can they go back to CrossFit? Can they go run a marathon? Right? Because they all have a goal, and you're trying to get them to that goal. But first, retest. This is your blueprint. Just go off of this and see if they can get better, right? Bias should no longer exist. So at this point, if they're coming in and they're passing all those reassessments, if they're going to go down towards their toes, and before that lit up their back, now they go down, duck, no more pain. Perfect, no more flexion bias. Now we can start to reintroduce some flexion activity back into their lifestyle. Because remember, at this point too, I've been telling my patient, hey, listen, I don't want you bending down to tie your shoes because that hurts your back. So I've been telling them to avoid their triggers. So now I've been telling them to probably tie their shoes like this, right? Because I want to avoid too much flexion. Well, now at this point, now I'm like, all right, you can probably start to add a little bit more flexion into your daily life. We still want to strengthen you in those kind of phases anyways, but now they shouldn't really have that flexion intolerance at this point, right? So, and that's super important too. You want to make sure that after that first visit, after you found what triggers their pain, and if it is flexion, well then you got to let them know, hey, listen, there's a lot of things that you do that are probably flexion based, in terms of you probably brush your teeth and then you spit back into the sink, you're going into flexion. That's going to probably hurt your back. So you're probably going to have to do something differently so you don't keep aggravating your lower back, right? When you pick up your kid, the car seat, you're going into flexion. That's going to aggravate your lower back. We don't want this to keep on reoccurring. We don't want this to keep us from making progress in your treatment plan. So we're going to have to do this a little bit differently. You're going to bend your knees. You're going to swoop it up this way. You're going to keep extension into your spine, and you're going to lift it up. So you're going to have to show them some of these modifications in their life so that you can make progress with them when it comes to the rehab. Okay, so at this point, you should no longer have flexion, extension bias. Your patient should be relatively pain-free and is returning to most daily activities before starting treatment with you. Woohoo! This is what we're trying to get to all the time, getting them back to what they love to do. Next phase of progression is strength, speed, performance will be tailored to the patient's goal. Not everyone's going to want to like do crazy exercises, right? So like what is, again, at the end of the day, what are your patient goal? If it's to get strong, usually I tell them, okay, you got to add some kind of component of pushing, pulling, squatting, lunging, hinging, carrying, because at the end of the day, this is what we do, right? We push a door open, right? We pull or open, lift boxes sometimes in our office, right? We have to lift our kids up. So you have to incorporate these things into your protocol, because if you're just running on a treadmill, how is that accomplishing you getting stronger in any of these movements that we have to do on a daily basis? You're probably not. So I always say, okay, how can we get you stronger within these modes? Because it's just going to help you for the rest of your life. We want to build a strong spine. So we got to incorporate some of the most important things that you do on a daily basis. Not just, you're out of back pain, cool, go ahead, live your life. You probably want to still start to say, how can I squat better? How can I lunge better? And how can I hinge better? I don't know if everyone's heard the word hinge in here, but hinging is actually how we're supposed to be moving our hips and our spine. We're supposed to be thinking of our hips like a door. It hinges. So the hips come back first. Most people's mistake is that they move their lower back first, right? So they're flexing their lumbar spine over and over and over again, and they're not using their supposedly should be mobile hips, because if our hips were actually very mobile, we can bring our hips back and our spine stays neutral or relatively neutral and not overworks our lumbar spine. So everyone on this planet should learn how to hinge correctly. And if you go to a really good PT or if you go to a really good personal trainer, they should be teaching you how to hinge, because that is actually what's going to save your spine from having those injuries. Honestly, hinging is very important. It should feel right. Encourage your patients in that phase. So developing the hinge, everyone can look at this. All these video clips I included the link. So when you open up the PowerPoint, that link, it will be there so you can get all of these videos. And this is just a progression. You can start from your knees, working on the hinge. You can then go to your feet, work on the hinge. Then you can even do it with a kettlebell. Again, when you lift anything off the floor, you are hinging your hips. So if you're not doing it correctly and you do it a lot throughout the week, you're just nicking at that lower back a little bit each time, and it's eventually lower back pain is 80% of the world's problems, right? In terms of musculoskeletal, it's obviously happening for a reason. We all need to work on it, and probably going to help. So, good. Those are our objectives. Here are the sources. Check me out. If you have any questions, I would love to help anybody who needs help. Oh, yeah. So I taught a seminar last year with Anthony, and it was all on rehab. And we recorded the whole entire seminar. It's up on ACE Seminars website, and I did it not only on the lower back, but I did it for the neck, the shoulder, the knee, the wrist, the elbows. So if you're looking for more exercises, more stretches that I use every single day in my office, there's a recorded webinar. So you can definitely do that as well. And like I said, if anyone goes back to the office and like, I saw this, or I don't know how to do that, and what exercise would you do here? What do you think is going on? Text me, email me, whatever. I'd love to help. Okay, so thanks so much.